Let's talk about pneumonia, ARDS, and effusions. So pneumonia really comes into a couple different types. So we're going to talk about lobar, broncho, and then interstitial or atypical. Just as often, and I think there's increasing pushes to sort of emphasize the recategorization of pneumonia in terms of whether it was community acquired or hospital acquired or ventilator, associated. We'll talk about exudate effusions, not transidate, and then a little bit about ARDS, acute respiratory disorder. So really, just any infection of the lung parenchyma that's caused by microbes. This is going to bring in tons of fluid into the tissue. It can cause VQ mismatch. In extreme cases, it can be called a shunt. It can cause diffusion issues as well. But for pathogens to get in, they've got to bypass the cough reflex, the mucociliary escalator, and macrophages. So usual suspects: influenza, streptococcus pneumonia, Haemophilus influenza, and Staphylococcus aureus. So like we mentioned, there can be a community-acquired pneumonia. There can be hospital-acquired nosocomial. This is going to be a little bit more serious, but person probably has a weakened immune system already, so they're maybe a little bit more susceptible, a little bit more vulnerable. Also, the microbes are more likely to be resistant to antibiotics. Now, there's a subset. It's kind of funny because this is already in the hospital, but nevertheless, a subset is ventilator-associated pneumonia. So these people are probably really, really sick, so it's an extra large issue. They also can't cough, right? That's one of our defenses. We can cough and get the phlegm up, or we can spit it out or swallow it into our stomach where it's dissolved, but these people can't. So the old categorizations, we have bronchopneumonia, which is pneumonia throughout the entire lungs. Sometimes they can cause consolidation, which is really just exudate in the alveoli. Then we have atypical or interstitial. Sometimes this is called walking pneumonia, so it's a little bit more indolent. So it can kind of creep up on a person or maybe be benign, so this can be more infectious potentially. And again, interstitial just means that it's, like in between the grains of sand. It's in between our alveoli here. And then lobar pneumonia, where it's really just consolidated to one whole lung. And this does cause consolidation. So I keep using the word consolidation. What is that? This is where the alveoli become filled with fluid. Fluid is radio opaque instead of radio translucent. So notice this is the lobe here is now consolidated, right? It consolidated, it looks like one. So it's just really a radiological term. It looks like one solid unit, and that's because all of the fluid makes it appear as if it's one complete unit. I mean, there's still individual alveoli. That's the same, but it just looks on a chest x-ray. That's the only reason. So fremitus, the sound increases. Fremitus is the vibration created by a voice. And we see from, I don't know if they actually did this, but in cartoons and movies and stuff, Native Americans would put their ear to the ground to hear, horses or whatever coming. And the idea is that sound travels better travels better through the sound than it does through the air. And that is true, at least that latter part. And so sound will be louder if it goes through the more solid fluid as opposed to the air. So fremitus increases. You get a most other percussion is going to decrease. If you bang on a drum, it's going to make more sound if it's filled with an air than if it's filled with fluid. And then you get bronchial breath sound. So bronchial breath sounds are normal if you hear them at the apex of the lung or the trachea. Bronchial breath sound is well, a normal vesicular breath sound heard at other parts of the lung in the periphery are going to be, I'm not doing it justice, but it's inhalation, quick exhalation. Inhalation, quick exhalation. For the vesicular, well, the bronchial is going to be an inhalation, pause, exhalation that are equal in length. Inhalation, pause, exhalation. So again, you're going to hear the bronchial sounds more often if someone has lobar pneumonia. So on the chest x-ray, bronchopneumonia is going to be, you're going to have these patches and it's going to be spread throughout the lung. Atypical pneumonia is it's going to look like interstitial fibrosis. It's honestly really difficult to tell apart. And in fact, they're both, so atypical is interstitial, but this is the same as interstitial fibrosis. So interstitial, they all kind of have these reticular-like opacities. There is a concentration in the hilar regions, though. But again, it's very difficult to tell apart. You probably need more information in the vignette. The lobar pneumonia is probably the easiest to tell. It's concentrated to a single lobe. People who are having trouble breathing, hyperventilation, that was one of our responses to hypoxemia. And pleuritic chest pain is going to be big. It's painful when they breathe. This is also going to be seen in tuberculosis and pulmonary embolism. So this pleurisy, this inflammation of the pleura, when they rub against one another, usually the pleural fluid reduces the friction, but because it's inflamed, they're going to rub against each other. It's going to be difficult when you take a breath. So looking at lobar, which is probably the most important one to know, S. pneumonia is going to be the main culprit here. So again, a consolidation, which is just exudate in the alveoli and the bronchioles. Again, this is dull to percussion, but it's hyper tactile for the vocal fremitus, so that increases. So this is normal. We now get an infection. The congestion for the first 2 days, it's kind of a red-purple. I'll put emphasis on purple because it's red in two phases. So there's some exudate at this point, as it makes sense, though, that this is mostly just bacteria because you just got infected. Your immune system has not mounted a response. After 3 to 4 days, we have what's called red hepatization. So now it's sort of a brownish color. Now the exudate has red blood cells, white blood cells, fibrin, bacteria. So clear signs of a proper immune response. The liver is going to look a little bit more solid and liver-like on the I guess it's gross morphology, but as well on the chest X-ray. And then we have the gray hepatization, where now the red blood cells are being broken down to the exudate, and that makes it look gray, and then the bacteria has been cleared out. And then a couple more weeks after that, the rest of the exudate is broken down, and it sort of gets back to normal. So again, the whole idea is that it's the consolidation is because it's filled with fluid. The fluid is an exudative fluid. It's filled with proteins. It's filled with leukocytes. It's filled with lots of cells and macrophages and all that good stuff, cytokines, proteases, you name it. So that is exudate. There is a leaky interstitium. That is how they're getting through. It's an inflammatory response. So that is, for the most part, reversible. They get filled with fluid, but it's reversible. This can progress if the immune response gets bad enough. This can cause an autocatalytic immune response called ARDS, acute respiratory distress syndrome. This is like the septic shock of the lungs. So it's really a lot of the same pieces of the puzzle. We have this inflammatory response, which causes the endothelium to become leaky. Fluid is going to rush in. The difference is that this one is a little bit less reversible, a little bit higher mortality rate, and often there's going to be a fibrosis and a destruction of the alveolar wall, replacing it with a hyaline membrane, which is just like dead cells, surfactant, and proteins kind of smushed together. And this is what it looks like on a histology. So it's usually, ARDS is usually an exacerbation, a continuation of pneumonia, but actually sepsis is even a little bit more common. So you can really just think of it as a non-cardiogenic pulmonary edema. Again, we also get fluid with just regular pneumonia that does not progress to ARDS. So the AA gradient goes up, whether we call this a VQ mismatch or in severe cases a shunt, or we just notice that it causes diffusion issues. We also are going to have an increased arterial oxygen pressure to inspired oxygen ratio. It's going to be less than 300. Honestly, I'm not sure why they do this. I don't know why we don't just say that the AA gradient is up, or even just say that the arterial oxygen value is down. Very important is this opaqueness, which is a little bit more homogeneous. It's blurry. It's kind of fuzzy. I really want to distinguish this from the atypical. Atypical, which looks like interstitial pulmonary fibrosis, again, has those reticular honeycombing opacities. This is just a big old cloud, and it's really, really important to pull out on a chest X-ray. ARDS, just like neonatal respiratory distress syndrome, can destroy the surfactants, destroys destroys the cell wall as well, but emphasis on the surfactant here, which can lead to alveolar collapse.